Okay, so let's just do this question together. Organs that respond to a particular hormone are called well, the answer is going to be target organ, right? So those particular organs will have receptors to that specific hormone, right? So those are the target organs. Not integrated organs, not responder organs, and not hormone attack organs, okay? So target organs for the hormones. Okay, so let's talk about growth hormone imbalances. So growth hormone comes from the anterior pituitary and affects many, many tissues in the body, right? And I think we listed some of them before, the bones, the muscles, the soft tissue. It's heavily involved in growth. Okay, so under secretion of growth hormone in childhood is going to lead to dwarfism. So pituitary dwarfism, right? Over secretion of growth hormone in childhood is going to lead to gigantism. So if you have a pituitary adenoma that's secreting large amounts of growth hormone as a child, well, their growth plates haven't closed yet. So the bones are going to grow and grow and grow, leading to gigantism. Okay? Whereas if you have a pituitary gland that is producing inadequate amounts of growth hormone, it will lead to pituitary dwarfism. Okay, what about hypersecretion of growth hormone as an adult, right? So the long bones, their growth plates have closed, so they can no longer get taller and taller and taller like a child. Well, this leads to a condition called acromegaly. Okay, so there'll be significant amounts of soft tissue deposition around the body, and we'll talk about acromegaly coming up. Okay, so low levels of growth hormone as a child leads to pituitary dwarfism. It's where the growth hormone is excessive that it changes depending on whether you're a child or an adult. In a child, it'll lead to gigantism because their growth plates are still open, acromegaly in an adult since their growth plates are closed, and the long bones just can't keep on growing once the growth plates have fused. Okay, so let's talk a bit about growth hormone. Another term for it is somatotropin. So somato is body, tropin would be growth. So the growth of the body, somatotropin is the term for it. Again, produced by the anterior pituitary gland. And we consider growth hormone an anabolic hormone, meaning it's a tissue building hormone, as opposed to something that's catabolic, meaning it's breaking down tissues in the body. Okay, so growth hormone is an anabolic hormone by promoting growth of tissues. Okay, its main target tissues are bone and skeletal muscle. So it's going to increase the length and also the width of bones. It's going to stimulate cartilage, skin, and connective tissue growth. Okay, so it can only lengthen bones in children. It can't do it in adults, but it can do all the other effects. Widening of bone, stimulating cartilage, increased connective tissue growth. Okay. So now growth hormone is also going to stimulate protein synthesis. Remember, it's an anabolic hormone, meaning it wants to make the body grow. So it's going to stimulate protein synthesis around the body. It's going to break down fatty tissues around the body to use as fuel, but it wants to build its protein. Okay, And why does it do that? Because it's increasing muscle mass, and it's also developing bone growth and soft tissue growth. Okay. Okay, so just briefly here, because we already mentioned it, so dwarfism, so pituitary dwarfism, what happens is following birth, a child doesn't follow a normal growth pattern, right? So children come in frequently to have their weight taken, to have their height taken, and their head circumference to make sure that they're not developing hydrocephalus, right? Which would make your head larger. And we plot these on graphs to make sure that they're following a certain growth line. So in dwarfism, well, you wouldn't be following a normal growth line. It would become very quickly obvious that you're under the 5th percentile or even lower in terms of growth, right? You're going to have a short stature. So that could be a tip-off during checkups when we're checking people's ages, heights, weights, and head circumference, that we'll see that their growth is really falling off the growth chart. Okay. Now, this can happen at birth, so growth hormone deficiency in children, or it could happen later on in childhood, caused by some kind of a head injury, infection, or a tumor in a child. Okay, gigantism, excessive production of growth hormone prior to the closure of the growth plates, sorry, results in gigantism, right? So it's pretty rare, because it will be noted on growth charts that this child is growing at an accelerated rate. Okay. So that's the importance of why growth charts and weights and head circumferences are done in offices. Okay. The most common cause of gigantism is a benign pituitary adenoma making excessive growth hormone. Okay. And what can be done about this? Well, surgery can be done. And pituitary surgery is usually done through the nose. If you recall the location of the pituitary gland, it's actually not very far from the back of the nose. So often the pituitary gland is accessed through the nose for surgery. Okay, and here is growth hormone access as an adult. Okay, so say for example, this adult developed a pituitary adenoma, not as a child, but as an adult. It will lead to a condition called acromegaly. Okay, and often it leads to bone deformities, because the growth hormone is still stimulating the bones, but they just can't lengthen, right? Because the growth plates have fused. And it often leads to arthritis because of all the stimulation of the cartilage and the bone. And typically, these people have a lot of weight, right? Remember, it's an anabolic hormone. It's increasing tissue production. Okay, so they often end up with a lot of arthritis, and typically they die prematurely from heart failure because of the excessive growth hormone stimulation. They die at an early age from heart failure. So the treatment again for acromegaly would typically be surgery to remove the pituitary adenoma, plus possibly radiation if the entire tumor was unable to remove. Okay, so it just depends on how accessible the tumor is to surgery. Okay, so this is showing you a transsphenoidal approach to the pituitary gland. Okay, so through the nose, and you can see that little tiny bony sac called the sella turcica, and that's where the pituitary gland lives, in that little bony sac. So definitely the best way to approach the pituitary gland is transsphenoidally, okay? And that's what's often done for pituitary surgery. And remember, the aim of pituitary surgery is typically to remove an adenoma. So for example, if you have a pituitary adenoma secreting too much ACTH, well, that may be tried to remove through surgery, or growth hormone adenoma, or say a TSH adenoma. So any adenoma, which by the way is a benign growth, that's producing too much pituitary hormone of one kind, can be accessed through this surgery. Okay. The other thing that happens with pituitary adenomas as they grow is, yes, they produce a lot of one hormone, but as they get bigger and bigger, they start to push the other cells out of the way and squash them. So as pituitary adenomas get bigger, other hormones can be reduced from the pituitary gland, because that one particular adenoma is just getting too large. Okay. The other thing that you might want to remember, and it's not relevant to this class, but it will be relevant to one of your classes, is where the pituitary lives is actually where the optic nerves cross over in the brain, called the optic chiasm. And as the pituitary gland gets bigger and bigger and bigger, it starts to press on the optic chiasm, and you start to get visual changes, because some of the nerves that are traveling from the eyes to get to the occipital cortex are now being compressed. So patients can come in with visual loss. So some of their visual fields can be affected from a pituitary adenoma. Okay, so let's talk about some posterior pituitary diseases. And if we remember, the posterior pituitary stores ADH and it stores oxytocin. Okay? So in terms of ADH, if there's a deficiency of ADH, which is antidiuretic hormone, there's going to be less of an ability for the body to reabsorb fluid in the kidney, right? So there's going to be a loss of fluid homeostasis, and there'll be tremendous losses of water into the urine. So you'll have very dilute urine, and you'll have concentrated blood. And this will typically lead to dehydration, because you're not able to reabsorb water in your collecting ducts, and most of the water is just going down the collecting ducts into the urine. Okay? So your plasma will be hypernatremic, so high sodium in the blood, potentially high potassium in the blood, because of all the fluid loss. Okay? And that's really why it's called diabetes, because it has similar symptoms to the typical diabetes that we think of, called diabetes mellitus. But that's where the similarities end, right? So in diabetes insipidus, sure, you're going to be urinating a lot. You're going to be thirsty. You're going to want to drink a lot. And that's why the term diabetes came into place. But otherwise, it's confusing because diabetes mellitus is related to insulin, and diabetes insipidus is related to an ADH deficiency. Okay, so let's look at the urine in diabetes insipidus. So it'll be very dilute urine, and it'll have a low specific gravity because it's so dilute. Okay, it's not concentrated urine at all. Okay, so let's look at SIADH. So the syndrome of inappropriate ADH secretion. So this could happen from a pituitary issue, but it's also very common in cancers, in particular lung cancer. So certain cancers produce ADH, and when excessive ADH is produced, it causes tremendous amount of fluid reabsorption from the kidneys, leading to an excessive blood volume, which can lead to edema, pulmonary edema, or pulmonary congestion, electrolyte abnormalities. Which one? Well, you're reabsorbing so much water that you're going to be hyponatremic. You've diluted your blood. What's going to happen in the urine? Well, you're going to have very concentrated urine with a very high specific gravity. Okay? So I hope that helps clarify these two conditions. Okay, so I'll just go through this diagram. If you find you totally understand it, no problem, just skip the slide. So how does ADH usually function? Well, it detects an increased plasma osmolarity, meaning I have too many electrolytes in my bloodstream, in particular sodium. Okay, so I had a salty meal, I have increased plasma osmolality. Okay, that causes secretion of ADH from the posterior pituitary where it's stored, and that leads to reabsorption of water in the kidney tubules. Okay, that leads to increased plasma volume, and it also dilutes the blood, which is exactly what it wanted to do because it was detecting elevated plasma osmolality or osmolarity. Okay, and by doing that, ADH stops being secreted, right? It's inhibited because the osmolality has returned to normal. Okay, so ADH is really involved in maintaining fluid balance and maintaining fluid concentrations of electrolytes. Okay, and it's triggered by elevated levels of electrolytes such as sodium in the bloodstream. Okay, a bit of a repetition here, but repetition isn't bad. So syndrome of inappropriate ADH secretion. So too much ADH leads to too much body fluid because of reabsorption in the kidneys. Okay, so this can be caused by some kind of an injury to the brain, meningitis, encephalitis, but we see it more commonly in cancers. Since cancers produce all kinds of odd molecules, some of them produce ADH. Okay, so fluid and vascular congestion, edema from all the reabsorption of fluid, water intoxication, electrolyte imbalances, in particular hyponatremia, and what's happening in the kidney and the urine? Well, reduced urine output, very concentrated dark urine with a high specific gravity. And we sometimes use ADH as a spray, as a nasal spray for children that have nocturia, so, or what's called enuresis, nocturnal enuresis. So what does that mean? Well, that's bedwetting, right? So as children get older, 8, 9, 10, a small percentage of them still normally wet the bed. Well, it starts to feel a bit inappropriate to them. They want to go to sleepovers. They're staying at a friend's house, but they're still wetting the bed. So sometimes we'll use a nasal spray, and the nasal spray contains ADH. So we give it at bedtime. What does it do? It reabsorbs the fluid in the kidney, and they produce much less urine. So the chances of them wetting the bed is vastly reduced. Okay?